You ready?
Okay.
Okay, we have a small group today, but that's fine. We'll just get, we'll have it recorded still, so we'll post it out there. So feel free to ask questions. Sarah, text me if I miss your chat, because I don't know if I can see that as well. I think Shanna can see it.
Yeah, I've got it up on my phone, so if anybody does put in anything in the chat, I can see it.
Okay, ECMO stands for extracorporeal membrane oxygenation. Big fancy word to talk about an invasive treatment that's used if you have a failing heart and or lungs. If it's just lungs, you can do respiratory support. If it's both, you can do cardiac and respiratory support. Oxygenates the blood, removes carbon dioxide, and oxygenates the blood outside of the body in a filter. It's really, it's not exactly like CRT, but if you think about it like a CRT, it helps you think about what's going on. Pulling blood out into a filter that's an oxygenator, same kind of thing, a bunch of tiny little straws in there, blood flows through, takes out CO2, adds oxygen. So this isn't a curative treatment. This is something that will buy us more time. They're dying from ARDS. We need some more time to fix the underlying problem. We need to oxygenate their blood for them. So we just completely take the lungs out of the picture, bypass them, use this, work on the lungs. So I talked about this a little bit. Two big types. Veno-venous would just be used for respiratory support. The patient has to have a native heart. Their heart has to be functioning properly enough that they can, pump their own blood through their body. Veno-arterial, or VA ECMO, you'll hear us call it, is when their heart is failing as well as their lungs. So this will provide hemodynamic support and essentially not completely bypass the heart, but bypass quite a bit of the heart, do a lot of work for the heart too. You'll hear some of these terms. ECLS is just extracorporeal life support in general. There's different kinds, there's different ways, so it just kind of encompasses all of them. The ELSO, which is like the governing body for ECMO, that's where that term comes from, ECLS. ECMO is the actual oxygenation on the device, and then you'll hear eCPR. We're hoping to not really do that here yet. It happens a couple times, didn't go well for us. This is something that more established centers usually have in place, where you'll be doing compressions and they'll cannulate to go on ECMO and completely bypass the heart and lungs. We went to a really cool conference 2 years ago now on targeted temperature management, but a couple ECMO talks came up, and a big hospital in Minneapolis is going to people in the field when they have coding, because big city, it takes a while to get to the nearest hospital. They'll, the code's 30 minutes away. They'll take like a mini mobile cath lab, go to the patient, cannulate them while they're still doing compressions, bring them back in, work on them. So we're not that level yet. Maybe someday. Right now, we're just trying to do what we can here. But if you hear that term, eCPR, we had a provider meeting and we talked about not doing this at Blessing yet, but like I said, you never know when you'll get that really young patient in, and I'm sure we would do everything we could. We do have the means to try it, so it could happen. I hope not. So all of these things are used to oxygenate blood, remove carbon dioxide when the lungs can't do that, give the lungs a break, and then they can also give some cardiac support. They have that bottom thing, if you're in the room, you can only see it, but it's a heater cooler, kind of like our targeted temperature management, but this thing's like on steroids. It's very intense, expensive, works really well. So we can keep them like at a very specific temperature if we want them warmer or colder. So ECMO's come a long way. It started in the 70s with pediatric patients. 1975 was the first successful case that they recorded. I have a picture of the little girl I'll show you in a second. Then it started really gaining a lot of interest in adults when H1N1 pandemic was happening. I don't think I was young enough, not necessarily in healthcare yet. I don't think I even knew how bad some places got hit with that, and I was wasn't aware yet. Is it like really close to my face? So that's when it kind of increased in adults. And then in 2015, we started what I was talking about, some of these big centers with the eCPR. So that's kind of where we come, and now we're using ECMO a lot across the country for sure, and across Europe. I also forgot to mention, like going out into the field, there's a picture that we saw at the conference too in France. They were cannulating somebody who had coded in a subway station. So it's going nuts other places in the world. I had to snip this out of an article, so it's not really big, but you can kind of get a picture. This is a 2-year-old girl named Esperanza that they ran ECMO on for a few days in 1975. It was their first successful case, what they would call a successful case of it. She was, I think they named her Esperanza because they didn't know her name, so they named her Hope in Spanish. And she was the first case that they had that Dr. Bartlett was the name, and she's in like our training manuals that we did, and also she's throughout all of that, she did a lot of work with that. Sorry, he did a lot of work with that. This is another picture I thought was cool. This is one of the first neonatal cases after Esperanza. So this was a baby, was born with a lot of congenital cardiac defects. If you can see in that first x-ray picture is the first x-ray that they took like shortly after birth. And it just that really big heart. She had the patent ductus going on they needed to fix, and just an enlarged heart in general. So then they cannulate her, and you can see that that second picture, like 4 days later, doesn't look great, right? Because they need to do, I think they had done a thoracotomy, it says, and they're in litigation of the ductus, so they're working on it. And it says it's just too small, but I just wanted you to see the picture of it clearing up, but you can see the cannulas in the patient at that point too. So then we go to 4 days after that, they remove the ECMO, and then 2 weeks after, ECMO support normal again. So they just gave, even though they knew things were going to get worse, they needed to work on the underlying condition, the heart. So they took the heart out of the picture, cannulated him on VA ECMO, and gave her hemodynamic support and oxygenation during that time, and were able to save her. At Blessing, we're going to use ECMO in the ICU or the CVU. Right now, just our CT surgeon, so right now just Dr. Arnold, will be cannulating initially, and then management will be a combination of a team. The CT surgery will still be involved, perfusionists. So we have one contracted here named Larry. He's fantastic. He runs the bypass machine in OR. So he will be a lot of help to us because this is essentially like a mini bypass machine. So we're going to need his support. He's been very accommodating. The intensivist is going to come on and help manage the patients afterwards in either unit. If it's a pure cardiac patient, like Dr. Cook, an interventional cardiologist will probably be on too. ECMO specialist is the 12 nurses at Blessing that we trained. Went through this book in 27 hours worth of online modules. Training, it was expensive. We hired a consultant to do that. And so we have, the 12 nurses have done that with Robbie, Rick, and Shannon and I had access to that information too. And then the provider, we had all the intensivists were in the perfusionist, because he wanted to kind of see the differences, were invited to all of that education as well. So they've received, if they've done the online modules and then they had the hands-on education that we had as well. So that's where the term ECMO specialist comes from. There's a lot of reasons that we're not just calling that ECMO nurse. One is staffing, right? It's the bane of our existence. We're always fighting it. So I don't want to call it the ECMO nurse, because they'll be like, oh, well, the nurse is in the room then. I want, especially while we're just starting, we want the ECMO specialist to run pump and a critical care nurse to have the patient. Maybe ECMO trained. At the beginning, we might try to do that, switch the assignments around to help the ECMO specialist get going. But another critical care nurse in the room and a respiratory therapist, we've talked with them, and I told them if we have this running, we really need one available at all times. And cardiology at the bottom. They might, and nephrology is on there, because this would be a patient that would easily be on CRT depending on what's going on with them. And then if their heart needs some more push, they do an Impella pretty frequently to help the flow through. So something, just like see how many pieces of equipment we could get in the room, and then we'll need more doctors to help with that. So who's the candidate? This is a big topic, because you want to make sure that it's people who could survive. Half of people that get ECMO die because all of them were going to die before they got it. The mortality rates of these people is very high. They're very sick. Severe ARDS patients, severe hypoxic respiratory failure, hypercapnic failure, cardiac support. Patient selection and timing is key. And it's been a really hot topic of discussion between all the physicians involved in leadership. So severe ARDS. So we've seen this with COVID, right? We've got some numbers up here, but think about like our COVID vent patients that come in. They were fine yesterday. They crapped out today. They're on bivent. They're prone. They're paralyzed. They're on FiO2 100%. What we did wrong at the beginning of COVID was like, well, we're going to try this for a week. Well, that bivent setting especially beats the crap out of their lungs that time. It's necessary evil to help them survive. But then what we learned from some of our earlier cases is, you know, well, they need ECMO, let's transfer them out because we don't have the program built yet. Oh, well, nobody will take them because they don't want their lungs, they don't see good outcomes with it. So they tighten their criteria down. Barnes, Iowa City, Chicago, I can't do what was that? Peoria. So we, you know, we made some mistakes early on because we just didn't know, for lack of better words. So going forward, we had a lot of talks about like 48 hours. They come into the unit, go ahead and call Dr. Arnold, have him like have eyes on them so he can think about it, talk, collaborate, keep watching them. At day 2, let's not do it at 2 a.m. Let's do it during the day. Like, what can we do? Should we go ahead and cannulate now? Because that's what some of the criteria that we saw from like Barnes, especially like we're affiliated with them, it's a little easier to talk to them about things like that's some of their criteria, just 2 days on high event settings. So Shannon's got some more mortality rates in here for, you know, you're already doing the protective lung ventilation that you can, you're already prone, you're diuresing, you're doing the best you can, and you're not getting any better. Those are the patients day 2, early on, we need to go ahead and cannulate. Again, so, you know, metabolic acidosis, elevated intracranial pressure, all those things that we don't want to do to these patients would be another kind. Cardiac support. So this kind, like you'll see bridge to LVAD and transplant, we're obviously not a transplant center. We might still transport these patients out. The 2 cardio help pumps that we have are transport pumps. I'll show you, she's got a picture of that in here later. So cardiac arrest, again, you know, we talked about we didn't really want to do ECPR. It probably is going to happen. Really bad sepsis, that's just killing their heart. They're vasoplegic. They're just crapping out on us, that kind of stuff. Just true cardiogenic shock. That is something I'm excited that we could keep here. You know, we send a lot of cardiac patients out of CBU to go to Barnes, and they have to be 2 hours away from their family. And, you know, it's really just this really bad acute MI or cardiogenic shock that if we could just get them through it, they could stay. Inability to wean from bypass, we don't see that a lot upstairs. Arnold does really get his patients off of it, but that is 100% a possibility to need that. Some contraindications, if they have basically an irreversible injury or terminal illness, we're not going to cannulate them. This is resource heavy. It's very expensive. It's very invasive. There's some pictures. It's a garden hose going into them. Severe risk for bleeding, bleeding out, you know, that kind of stuff. I'm not going to cannulate you. And if we've been coding you for 45 minutes, not going to cannulate you at that point. At Blessing, that's, you know, and you will see that across the board, but I just say that to, you know, make sure we talk about like, that's what we're doing here. Ideally, we could cannulate in the OR. The CVOR is more used to this because it is a little more similar to bypass. They know the ECMO cart's down there. They know the supplies. They work well with Dr. Arnold and his first assist and perfusionist. So that's kind of why some of the stuff originated from CVU too, because we work so closely with CVOR on it. You could cannulate in the cath lab, or we have attempted cannulating at bedside before, a couple times successfully, a couple times not. They did cannulate in the ER one time too and tried to transfer her out down there. So all kinds of possibilities. The type that we're doing, the locations, and I don't have all these down perfect yet. I'm still learning this myself, but depending on if you're doing VV or VA, there's a lot of different cannulation possibilities. The most like gruesome sounding one to me is if you're not able to get them off bypass, he'll cannulate them centrally into the aorta. Sounds terrible. Don't do compressions on that guy. And then cannulations vary in size. So arterioles can go from 13 to 25, venous 19 to 31. A chest tube is a 32 French size usually. So when I say garden hose, like I really mean it. So, you know, ideally we don't want to be doing ECPR here. That's something like hopefully 5 to 10 years down the road, maybe we're doing that. That'd be great. I'm okay with holding off for now. But so cannulas are big. You can there's dual lumen cannulas. You can actually have your push and pull ports be in one lumen in your neck. And I think we have a picture of that on the next page. Yep. You could go femoral vein to an IJ, go this way, pull from the vein and put back up here. You could go to each side femorally, push and pull. Lots of different choices there. VV, they tend to like, which I assume that we're probably going to see more VV here at Blessing. We have those sick ARDS patients still creeping in, sometimes COVID, sometimes not. I would like, ideally, but it probably won't happen because this is what I want, but I would like to get one of those thick ARDS patients that we do early, like they don't have a lot of other comorbidities, they really just can't oxygenate and be successful with it. So for VV, they tend to like these dual lumen cannulation. The one thing about these though too, they have to be done under fluoro, so it would have to be in the cath lab or CBOR. But the big picture here is like you need to make sure that it'd be a lot of checking on CT and X-ray and make sure that, or not CT, sorry, X-ray or ultrasound, I think is what they would also do to check it later. Make sure where you're pulling blood in and putting it back is in the right spot. Because if you don't do that there's a picture of it later. Oh, I didn't realize that was that far. I'll find it later. You'll pull blood in that you shouldn't be pulling it that's not oxygenated yet. So the oxygenated blood will never get to the patient. It'll go right back into the circuit. So you just have to, it's something to watch out. And there's some things to watch for. We've all been trained on some of those things to watch for in case that might be happening. VA, they'll typically do like a bigger femoral vein to femoral artery, pull from the femoral vein, put it back into the subclavian artery, just all kinds of things. Like I talked about the bypass patients with that. Some more differences between VA and VV, the big thing to know is you're not going to get any cardiac support with the VV ECMO. They have to have a native heart pump. Their pump has to be working in the heart and the flow. They may need a little bit more inotrope help because you're not giving them any cardiac support and they're really sick still. Just kind of like an overview of what the machine is using. It has the pump and the oxygenator. The cannulas coming out of the patient connect to the circuit. There's a magnetic pump in our machine that drives the flow through, and then if you're acting as your heart too, it's pushing that blood through the body. The oxygenator attached to it, which is the red piece in the back, is the sweet gases flowing through, and it's oxygenating the blood and pulling carbon dioxide out at the same time. So that's kind of like a very basic overview of the system. There's all different kinds. This is what we have at Blessing, a cardio help. It's made by McKay, who makes like our balloon pumps too. We have a great relationship with our McKay guy. So what we liked about the cardio help is it's pretty user friendly as far as the ECMO circuits go. I just take Rick's word on that because I've never ran it before. This is what he tells us. And the consultants that we hired also they like this machine too. So the oxygenator is all one piece. Some of the other machines, they're kind of customized. And if you had like one piece break here, you could replace it. One thing about ours is you have to replace that whole set. If you look like Sarah, because you can't see, but that red part at the back of the machine in the left picture is the oxygenator. That's $13,000. It's a disposable circuit. So this is not just like changing a CRT circuit. A little bit more, just something to think about. If you look at the right picture, it's thrown in the bed. You can take that part off of this is just like a carport with a cooler on it. You can hook it up to an oxygen tank and you can transport with it. Hand crank for emergencies, just like CRT, but very similar if you had to hand crank. So some pros and cons with it, a little more user friendly. If something happens to the circuit, you have to change the whole circuit out, but it can also transport. Some ECMO pumps aren't transport pumps. So that would be like bigger facilities where they keep, everything there. So again, just a little more about the oxygenator. The way it makes the most sense in my brain is to think of it like the airbow. Because I remember when I was a new grad in ICU, the airbow was so confusing to me because there was this leader flow and this FiO2. And once I finally got that down in my head, this helps with, and it looks the same to me. You have your FiO2 flow, and then that's going to deliver the oxygen. And then the leader flow that you're pushing, so you can bump that sweet gas up too. You can make it go faster, and that'll take the carbon dioxide out if you need to do that. If you need to slow it down because you're taking out too much. That's how we're titrating this stuff when we're drawing ABGs and stuff. And we can draw an ABG right from the machine, which is nice. And, we got more of us trained on the gym, respiratory trained on the gym. So we have it right there. We can make some adjustments bedside. All this point of care testing is fantastic when you're running this kind of stuff. Okay, something for veno-venous that we were hoping some more respiratory people. We had some yesterday and had a great discussion. about this is going to look very different for them. You know, they're used to really helping us and just like taking ownership of that vent and doing everything about it. This will be not the case in this situation. We're not going to have the same vent settings. You know, if you go from those crazy high bi-vent settings and now I'm doing all of your lung support, that's the point. I want to get you off the crazy high vent settings so your lungs can rest. So you're going to have rest vent settings. And I know that I'm delivering more oxygen to the patient than what it's picking up on the pulse ox, so I'm okay with lower like SpO2 and SaO2 on the ABGs. Stuff like that is going to be hard for them. They're going to be trying to bump up the FaO2 on the vent. No, that's not where I'm oxygenating anymore. I want that at 40%, and I'm going to bump up my sweep gas. Going to be lots of communication and conversations with that. We've had good conversations with them so far, and I can, expect it to continue to get better. But just kind of something to think about as you're going. Veno-venous. Move on. Mixing cloud. I talked about this a little bit earlier, but if you can, this is something that could happen. It's a VA patient and you're going to recirculate the blood and it's not going to get to the patient. You're going to know, they call it Harlequin syndrome. Sometimes they're going to be like purple from the head up because there's no blood flow going up. It's just going down. So something to think about. We're always going to be assessing oxygenation in these patients. The cannula could be in the wrong spot, especially like that dual lumen one I talked about, something that you would really need to get like a stat x-ray and notify the providers. You'll know the lungs are getting better when your SaO2, your CO2, your numbers get better without a ton of changes in the system. Then you know where you need to be and you're giving the lung rest. You can continue what you're doing until you can work on weaning them off. Bleeding, it's a huge complication. These patients are, we're running heparin, to keep the blood running through the system. And then we have garden hoses in them. So bleeding is a major complication. When we put that order set in and initially to cannulate, we put packed red cells on hold to stay on hold, make sure platelets are in house. A lot of things similar to kind of like an open heart patient we would do, again, for the same concept, or trauma, their risk of bleeding. Hemolysis, so that venous pressure that's pulling the blood out, if we need that higher for whatever reason and we get it too high, it'll start breaking down those blood cells. A pump failure, there's a clot, it can cause like an actual mechanical failure in the pump. Air emboli is a big one. If you see us freaking out, clamping stuff, tapping the circuit, we're trying to get air out of it. So something to know for, bedside, I told RT this as well. If I'm telling you like, hey, I've got air in and I'm freaking out, because I probably will be, especially the first few times it happens to me, I need to make sure that the arterial line is clamped because I don't want any blood to get back to the patient. The circuit will still run, kind of similar, again, like our CRT. When you're still circling, it'll still, so that blood doesn't clot up in there. I have a little bit of time, and I'm going to like be trying like crazy to figure out what the hell's going on and get the blood out. Decannulation, obviously it's an emergency. Go ahead and try to hold pressure. Good luck if it's VA. Just call the surgeon. Yell for help, call the surgeon. Absolutely. Either one, but VA, it's going to be a bloody mess very quickly. They're going to sanguinate so fast if it's just too big of a cannula. So, we're still going to do a neuro exams on these guys. We're going to look for signs of stroke, especially in VA. Clots can still move, unfortunately. All these same kind of things that we're used to looking about with our really sick patients, just don't forget. Again, this is why, especially starting out with the consulting company we hired recommended and what our thought is, staffing is always hard, but we want the ECMO specialist to sit pump them. So we do still have that other critical care nurse to keep eyes on some of this stuff. We get more established, we're a better program. We've had people who actually have some experience with this. Yes, centers definitely run with one nurse to one-to-one, like you would be with a CRT and a bunch of drips or something, a little more intense, obviously, but we'll get there. It's just like at first, we're not going to do that to neos because I want to lose all my ECMO nurses because they're like, forget this. So you're still going to do your assess for respiratory complications. This is our basic stuff, guys. Like listen. Make sure you don't get a pneumo. They're really sick. They're on the rest vent setting, so you shouldn't have that high PEEP. Shouldn't get a pneumo, but yeah, I've had my patients get a pneumo that I wasn't expecting either. Sick patients, if we did have to have the PEEP up for a little bit to get some more compliance, that could happen. If for some reason you had to put a chest tube in, you need to you have to talk to the doc and think about your heparin and what you're doing with that patient. Always think about gas exchange, looking at our numbers, knowing that our CO2 or O2 or SaO2, they're all going to look a little different, but making sure we're on the right track. And I don't need to be making changes to my pump. We don't need to be doing something with drips or like, are we missing something else that's going on? So same as our other sick patients, really. Anticoagulation is going to look a little different. We're going to run heparin. We're going to do a loading dose like right as we cannulate of 100 units per kg. Yes. And then we're going to run heparin. And what the lab started for, so they've been working on it for a while, was the anti-factor 10A. So instead of a PTT or an ACT, we're going to use this. It's a little more specific. I don't remember why right now. I cannot tell you it's more, they're getting there because it's more accurate. That's what I want to say. It's a more specific to whatever, right? I don't know the specifics on that. I can't remember them. I was told at one point. So that's what we're going to for sure use with these guys. Like I said, we got that set up with the lab. If we're running labs on these that we'll need emergently, what we do with our open heart patients, because we want our labs back right now when they hit the unit, is we send down a blue paper, says they're open heart, blah, blah, blah. Lab has gotten used to seeing that. So we're going to make a similar thing for these ECMO patients. Do these now, please. Don't throw them in with the rest of the ER, and like it'll be run 2 hours later. And don't get mad at me when I call, because the anti-factor 10A can't be point of care. So we try to get as much things as we could right next to us in the room. Like there's so much you can do on the gym, which is great. So that's really helpful. Your ABGs, you can even do the ABG complete and get some lights on there, H&H. There's just some things that you can't do. And this is one that has to be sent down for the labs. So, watch for bleeding, make sure it's not something you can fix. There's going to be probably some bleeding happening, but it's not something we want to have happen all the time. I say that, but then I also say, we talked yesterday about how you do want to make sure these patients are sedated, especially at the beginning, to get them through it. But if they are starting to wake up, like we've had those patients, I'm not saying every patient, some patients have to be snowed to keep them safe, but we've had these patients shouldn't have to be paralyzed anymore. We can start coming off that stuff. We can wake up, but they're just lungs aren't ready yet. When, again, 2 years ago at this conference, they had pictures of people walking with ECMO cannulas in their groin. They're like, oh, they just oozed a little bit. Like, what the hell?
Dr. Arnold told us in our meeting with physicians, he said, that's when you know you've really made it in an ECMO program, is when you can walk your patients. So, of course,
we're going to get there.
Oh, I know.
Ultimately, like
that's a specific type of patient too.
Right, like that, right. That's the goal.
Yeah.
So you kind of see where we're going with this.
Think about some of these 50-year-olds that have gotten COVID and they have like diabetes and rheumatoid arthritis and COVID, and they can't oxygenate with a crack, because those are some potentials, right? Get them through that. Their lungs still need some time, but they're they're awake. Let them wake up if they can handle it. Maybe some light sedation, because that would freak them out. Absolutely. And then we'll try to start doing it. We can try to start moving him. Like I don't need to talk about how much Rickelman's passionate about early mobility. It was my master's thesis too, and part of Shanna's. So we're all passionate about it. We all see the need in it, and we know we need to get a little better. So I haven't seen those ever in a long time.
Indicated in ortho anymore, but for our patients, maybe that would be good. Just, it's a continuous. I don't know what I see something.
Yeah, I would try to start like as I was turning patients, and I had to Cameron, but pounded this into me when she would turn with her to move, like do range of motion as you're turning, like move around, like makes sense.
Chair position.
Yeah, we use a chair position in CVU all the time. Using it more elsewhere would be. I know, but working on that. Yeah, we're trying to get new beds, so kind of using that co-mobilizer that we have. So something else that can happen, hypovolemia, a lot of times you have to be careful. You want to watch this. A lot of times I think our answer, and I know my answer, because CVU will pick on me sometimes that this is the ICU in me, because I just want to throw volume at it or push this, slam this in. Like, no, that's not what we do up here. So I've learned a lot about hemodynamics, but another thing with this one too, but it's that those lines coming to and from the patient will start having chatter if it's hypovolemic, because you're pulling real hard, right? That venous pressure pulls really hard out. Big tube pulls a lot of blood to get through it, so it'll start like chugging or chatter, they call it. You need to do something. You might need to increase your speed and give volume. They might need more volume. You need to start checking stuff out.
Do they have similar like fluid shifts like the CRT, like at the very type of tension and stuff?
Yes.
Just because you're shifting.
They do, and there's 600 mils of blood in the set. But if you take an H&H, so yeah, that initial thing you need to think about. But now then, if they've been running for 12 hours, that if you take an H&H, then that 600 mils is not like coming out of them. It's like outside the butt. It's just part of it, you know. So yes, at the beginning, but where I would think it's, I guess, similar as CRT or a little different, it kind of gets into the whole set of blood. Does that make sense? Your H&H is not going to be inaccurate later if you take it later because it's already been running out. Volume, inotropes if you need it. Always have a plan for that. So increasing flow for VA ECMO, sometimes that's not going to fix your hypotension. You need to see like what else we can do and make sure that your cannula is in the right spot. Remember, like you're giving all of their cardiac support. So if you're having hypotension, something's going on. You need to figure that out. They might just need more volume, maybe more flow, maybe more RPMs, a little faster. And definitely if they're starting to crap out on you, that's what they tell us to do. Bump up your RPM, like you're driving the car, go a little faster. You know, see if you can help it out. Tissue perfusion, obviously you can see how there could be a lot of complications with this. I think I hit on this a little bit. The cannula size, the wrong size, needs a different size, moved out of place, God forbid. No, I went over that earlier so you can see, no, you're fine, but you can do neck, vent, femoral to femoral, femoral to subclavian vein, return to clavine. If it's like a bypass case and you can't get them off bypass, we don't see that here typically. He could go centrally into the aorta, which I think would be terrible. But Doppler bilateral extremities, you know, check what's going on. This is the same stuff again. You know, if we're on VV, we could still be on a lot of vasopressors. Like, what are we doing to the patient? Are we causing some of this? Is it just some of that? Just make sure that your circuit's good. We have in our checks to do like an hourly circuit check. But just if you're in the nurse in the room too, it's something you can keep eyes on. This is kind of a big deal, something to think about. If your patient is on VV ECMO, so you're just giving respiratory support, and they go into asystole, what do you do?
So where it says no.
No, you give compression.
Okay.
Yeah.
That's only open massage by providers.
That's for central cannulation.
Right.
That terrible one.
Centrally cannulated and provider's not around.
Your provider's going to be around if you have a centrally cannulated
We're not
ECMO
gonna
patient
have
here.
that often. Okay.
Yeah. I don't think Arnold is going to be leaving 5 feet away from the patient if we have a centrally cannulated.
No, he's absolutely not, because it'll be his patient too at that point. They probably wouldn't even be intensivist on the patient.
Yeah,
just
that would be a
his.
bypass patient.
So VV ECMO, just lung support, they go into VFib. You're absolutely going to do compressions. You're going to run the code basically like normal. You're going to bag them. And you probably, and I think I forgot to mention this earlier, maybe it's somewhere else, but when you go for VV patients, when you go to cannula ECMO, you turn down your vent, you want to write down, you or RT, make sure one of you writes down your emergency vent settings. What crazy high, crappy settings were you on right before we cannulated? Because then code, absolutely. Or God, my circuit messes up, I need to do emergency circuit change, takes me a hot minute, go back, yeah, on the vent. That's what we had said. So yeah. So just something to think about. VA ECMO. So if they code, which is this tricky, guys, because you're not even always going to feel a pulse, right? It's like a flow thing with this. It's pumping blood and it's flowing. If you had an art line in, there might not be a pleth. Like, it's going to be weird. You just have to look at the color of your patient, look at your labs, look at your ABGs, and I'm titrating things on this pump, and that's how we know we're getting to where we need to be, and hopefully we're getting neurostatus back. You won't do CP. Yes and no. I think it varies because there's some native flow. I'm not taking it's not like cardiac bypass where I'm taking all of the blood out of the heart completely. There's still some native flow. That's why you can get that mixing cloud. Yeah, you would, and then you'll get.
It's not normal, but this is different.
So you can give, you're not going to do CPR is the big thing, basically. Obviously, if there's big tubes coming out of here, I think we would all know, I would hope not to do CPR on that. But even if they're cannulated elsewhere in this VA, you're not going to do CPR because it's still giving them a pulse. So it's weird to think about that. Now, so you can give meds, but the other thing to think about is that oxygenator sucks up meds sometimes. And where do you give it? It could be a while till it gets to them. So if you are giving a med, if they're in VFib and they do want to give meds, fine. No, it might take a little bit longer. The patient still has a pulse. Of course, we want to get them out of VFib and we can shock them. We can still do some things. Don't give compressions because you're just going to end up causing more damage. That's a bleeding risk in itself. that we have to do. Other times we don't have to do this time. So arrhythmia, hypothermia, like what's going on with them? We have to figure it out. If they're coding, also this would be a really bad sign, right? If we're coding on VA ECMO, and it's probably time to talk into life care. Okay, we're gonna start trying to wean. Like I said, like we shouldn't have to go back to those emergency settings. This is the point where we can start going, turn down the ECMO support, lower the sweep gas or turn it off, watch stuff and see how we're doing. If you can get your FiO2 down to 60% on the ventilator while you're weaning off stuff for about half a shift, you're probably looking pretty good. We'll decannulate in the OR. They might have to do like some patches, like sewing in the vessels and arteries and stuff. So we don't want to decannulate bedside. VA weaning is a little more complicated. You gotta, sorry.
That should be the infusion center.
So just right down by the north entrance.
I would go down that way and see where everybody's going, because it might be upstairs, it might be downstairs, I'm not sure. See ya.
So you're gonna wanna still like decrease your oxygen, but you're not going to turn it all the way off because you can cause right to left shunt situations with the oxygen in the heart and the blood, and you have to watch all your numbers. You might have to tweak your vasopressors as needed. It's going to be a balancing act, and it's going to take a little while to figure out. And this one is going to take a lot of support from the physician as well. They might even want to be like, well, we can let the heart do its thing, but the lungs need more time. We'll switch to VV ECMO instead. They might need to switch a cannula out or something too, depending on where your cannula is. So there's all kinds of things. I don't know what this looks like yet. We got to see this for the first time. I have an idea. I've read a lot about it, but and I think every patient is going to be so situational and like depending on what's going on with them. So that'll be something we'll do. Something that, we can run CRT right from the circuit. There's ports, just like we can connect ports like this to both sides of the oxygenator, and you can run your pre and post right to the circuit. So you wouldn't want to have to put a trialysis into these patients after you've cannulated again on a ton of heparin, bleeding risk. You shouldn't have to use as much of your vasoactive drugs because even in VV ECMO, because you're giving so much support to the patient, and the drugs will stick to that plastic and the lining of the circuit. Fentanyl was one they said, especially it'll be nothing to have patients on like 300 of fentanyl because the circuit is actually eating some of that up. It's not all getting to them. So just titrate to patient comfort with that stuff. And no, Dr. Pharmacy, Daniel and Abby have both been like awesome about even already knowing some of this stuff or looking it up. Abby has done some stuff with ECMO in Chicago, so she's got some familiarity with it, and she's been a great help. We'll draw our labs and ABGs right from the port at the bottom of the oxygenator, so that's super easy to go. We think we have something going on, we can't figure it out. Let's go do a test on the gym real quick. Maybe send some more blood down, but get like an answer right away so we can change something. We talked about these rest settings, knowing your emergency rest settings. This is going to take really good communication. We're really going to need teamwork down there. It could be a CVU nurse that's the ECMO specialist sitting pump, an ICU nurse with the patient, and an RT that goes to ICU more often. We need to make sure we have really good communication. Like when we can collaborate well, I think it's awesome and great. And this has caused a lot of people to collaborate together. The intensivist more involved with Arnold and stuff than they have been in the past. So it's been a good all the way around. So I'm going to keep that going. Just talk about it, talk about why, they might not have gotten to the education yet. They might not have looked it up yet. They just heard like this rumblings about this ECMO patient, and RT doesn't know why they can't touch their vent, because they like their vent. So there's a lot of communication between everybody will be key. So again, in summary, it's a supportive measure. It's not going to cure anybody. It just buys us time, lets people stay here, not have to go 2 hours away from their family, so we can try to figure out what's going on. It's a team effort, picking the right patient and doing it at the right time. And then it's a collaboration of just everybody that we talked about, the physicians, the nurses. The perfusion is going to be a huge help, respiratory therapy. And like everybody, like PT, they're, at some point we're going to want them to get them in there helping us with range of motion and stuff. And they need to know what they can and can't do. The aide should not be going in there and turning this patient for you. Make sure that you and ECMO nurse are in there. Like this is you don't want to pull anything out. And the last picture just shows our setup from our demonstration day. So you can wanted you to try to get a feel. We only have like 4 drips buckets. We don't want to take a bunch of drips from the floor. You'd probably be on a few more than that. Maybe not if you've been able to get off stuff. We, you have a cardiac output in there, monitor in there. We do Probably it'd be similar to like the cheetah, but these patients will be sick enough if we want that number, we want something more invasive. The ECMO circuit actually gives us like an SDO2 and quite a few numbers that we can use as well too. These their kidneys are going to get hit if they're this sick. They're probably going to end up on dialysis for a little bit, and then your vent. Just to kind of give you some ideas, you could add an Impella to this if we need to push more. The heart needed more help. The LV needed more help pushing through. So there's just a lot going on. A lot to a family member walking in, a lot to really any other staff member walking in that doesn't never seen this before, a lot for us, the first time we do it, where it's going to be a lot for us too. So we wanted to help give the hospital a picture of like what the heck we've been working on that took a year to work on, and like let them see what the setup would look like in a room.
This setup is in, we actually just used a patient room in the Mormon Pavilion. Obviously they're a lot bigger, especially a whole lot bigger than the ICU rooms. So it wouldn't be a surprise to anybody that, we may move an ICU patient that's going to go on BV ECMO to CBU just for the sheer ability to have more room. So, that's going to mean, staffing changes and location changes and, physicians being in different areas and things like that. So if you think about putting all that equipment in one of the ICU rooms, especially with the blowers in there right now, this is a really good case for us to make for a new ICU, which, is coming, but, so there would definitely be some changes just solely for, logistics and things like that. So that's just something to think about, if we are talking about this, like what kind of space do we have in those rooms? Maybe we might have to pull out everything else, put the bed in a different position, things like that, so that we can run this with all of the devices that are going to be needed. The pump itself is pretty small, but then you add the heater, the whole cart, the oxygen that it needs, and just the sheer issues with the possibility of decannulation and trying to get enough people in the room to turn the patient. We're still proning these patients, and think about these huge catheters inside the patient, and we're trying to prone with all of this equipment in the room too. So that's really something that we have to think about logistically and, the safety of our patients.
Okay. Sarah, let me know if you have anybody else on. I don't know if you have any questions. Just let me know.
Does anybody have any question? McKenna, do you have any questions? It's a lot, isn't it?
Yeah, it is. It's kind of overwhelming. Once I start seeing it, I'm gonna have a lot.
Yeah. Mm-hmm. Yep.
Okay. Well, we're going to go ahead and stop recording. I'm going to hang on, just check the chat really quick just to make sure, since I know some people don't have a microphone. I can actually. Okay. All righty. Thank you guys for coming.